Hi, welcome to House Call. I'm Dr. Brian McHugh. Today we're talking with a former colleague of mine who was a circulating nurse in the operating room I used to work in when my practice was based out of Washington, D.C., Ruth Gwynn. Ruth is a fascinating person who has an engineering mind and a background in IT and transitioned mid-career into a nursing program while she was raising 4 children. Ruth was diagnosed 4 years ago with glioblastoma, and since that time has been quite public about her journey managing that disease, including surgery, radiation, chemotherapy, and clinical trials that she's been a part of. Additionally, Ruth's cultivated a network of other GBM patients online and through various forums to support her through her journey. I think providers who deal with patients who suffer from GBM and patients who've had this diagnosis will take a lot away from our conversation with Ruth. She is an avid outdoors person. She's a beekeeper, keeps horses at her home, and spends her time with her 4 wonderful children. I really enjoyed talking to her. I think you'll enjoy listening. And now I present to you Ruth Gwynn. So what I was thinking, Ruth, is you started to mention IT and stress, and so that might be a good place to start. But
Okay.
as a way of introduction, we worked together at Inova Health down in Virginia. I was there in 2015 to 2019. We were trying to figure this out. You were there
And I started in 2016 and immediately joined the neuro team. I was,
immediately.
yeah, as soon as it became available, I joined the neuro team
Okay. And you were working
when it became a
there.
thing.
Yeah, it was a thing, right? You were always an operating room nurse?
Yes, I've never been anything else.
Okay. And prior to Inova in 2016, I know you had a previous career in IT. How did you go? Where did that all start? Maybe if we start back at the beginning, like you graduate high school, you're trying to figure out what to do. We do a little bio on
Um,
everybody, kind of their story, like where they came from, how they got to where they were. So you didn't go straight into nursing, which is interesting in itself. Um,
I did not.
you were an IT specialist, so maybe if you could tell us about how you got into IT, what you were doing there, and then how that work led you to say, you know what, I actually want to go into nursing, and how you did that, because that's not easy.
Um, well, I got into IT. I have sort of an engineering brain, and I was studying for engineering at the time. And then my boss and my manager allowed me to get into midwifery and do my um, postpartums and prenups, not prenups, prenatals, uh, on the side. And if I needed to leave to attend births, I would leave the workforce, the workday, and make up the time or just use it as sick time. So I started in IT and I started like spinning around, going from health to engineering. And then I decided to go to nursing school to become a certified nurse midwife.
Hmm.
Uh, I followed a nurse midwife and I didn't like what I saw. I had enjoyed the creme de la creme of birth, and I just didn't care for all the other stuff that went on with it. And I people self-selected me. They didn't go through a signing or something like that. They sought me out.
Right.
And so after that, I was like, okay, well, I've moved from Ohio to Virginia. I'm pregnant with my 4th child. Maybe this is the time to get into nursing school and see what I can do with it. I the best thing I can say is that I realized halfway through that I was making a mistake.
Really
And
interesting.
yeah, halfway through. but they didn't allow us to go in the OR.
Hmm.
Um, when I went in the OR, I was like, oh my God, I found my people. These are the
Ah.
people that I want to hang with. And they gave me a implant to hold, and I held some cement that heated up rather quickly. And that's where it came from. I'm not a bedside nurse. I am very compassionate about people, but I also have an engineering brain.
So I think the personal side of it's interesting too. So you were working in IT with an engineering background. You had already gotten married and started the family. And how many
Right.
kids? How many kids do you have total now?
4.
Four total. So you're pregnant with the fourth, but kind of restless professionally. Is that like an accurate
True.
statement? And
Yep.
you're kind of dipping your toe clinically with the midwifery, um, which is like a lot to do. You're pregnant, you've got three other kids, you're working as an IT specialist, and then you're also doing midwifery like on the side, basically. Is that accurate?
I quit when I got pregnant with my fourth because my husband moved to Virginia, and I couldn't do it right then, obviously.
Yeah. Where were you guys prior to Virginia?
Ohio.
Ohio, interesting. So your husband moved to Virginia. You were pregnant with your fourth, so you quit. Did you quit everything? Did you quit IT and midwifery?
Yes. I
Okay.
had to when I came to Virginia because I also ended up in the hospital with placenta previa and placenta precreta. So I was in the hospital. I actually was in the hospital at Nova Fairfax.
Wow. So the pregnancy had some complications. You guys made a personal
Quite a few.
family move to Virginia, so there's a lot going on. So you're not working during that period, but prior to the fourth pregnancy, you'd been working kind of double duty in IT and dipping your toe clinically into the nursing space with midwifery. That
Hmm.
that transition, like both the birth of your child and the move to Virginia, just kind of provides a break where you sort of reflect back and say, you know
Took a
what,
moment. Yeah.
yep, I'm going to go and I'm going to do nursing school. You're in nursing
Right.
school with a plan to be a certified midwife, and you're
Right.
halfway through that and you say, I'm making a big mistake. I don't think I want to do this. But part of the schooling gets you into the operating room. Is that right?
Yes.
Okay. And so
Yes.
in the midst of the schooling, when you're feeling like you're having made a mistake, part of the program sets a light bulb off and you say, well, hold on, maybe I'll be okay here. I seem to like the operating room. It clicks with my engineering brain. This is
Yes.
perhaps the blend that would fit. And you complete the nursing program.
Yes. I
Okay.
was president of the class.
Oh, nice. Nice. How long was it, Ruth? How long is, like, if you're doing
How
that?
long was it?
Yeah, you did it full time, or did you do it at nights, or how did you do it with such a big family?
Um, I would go off in my room and close the door while other people were here to take care of the kids, or I would put my youngest in daycare for like 3 or 4 hours and I would go and study.
Yeah. Is it were classes at night during the day?
No, it was an online hybrid program, and I did it at Northern Virginia Community College, and then I went for my BSN at University of Louisiana.
Oh, wow. But remotely, right? You didn't actually move to Louisiana.
Yes,
Right. And the whole process from beginning to end, how long does that take?
like 2.5 years.
Okay. And are you working part of that, or is it all school?
No, it was all school.
All school, okay. I think people like to hear this stuff. Like one of the interviews we did was with one of the CEOs of the local hospital here, and he had started his whole career as a respiratory technician. And then
Nice.
part of our discussion with him was just how did he go from respiratory technician to hospital CEO, and it was just this fascinating journey through all of healthcare. Um, so when I met you at Inova in the operating room for the neurosurgical team,
Right.
you had been there for a year. Is that math right? Because I started in
N- You started in
2015.
2015 and I
Yeah.
started in 2016.
Oh, okay. So I got there before you got there, and then you got there, and
I'd
at
heard
that,
about you though.
Ruth, we can't put that on the podcast.
We need to put that in the podcast because I'm not going to elaborate on it at all.
um, Ruth dealt with me when I was coming straight out of training, which is a very stressful transition, and if not mentored appropriately, you can feel as though you're on an island, and ultimately I ended up in anger management. I think that's the end
See, I
result of
wasn't going to
that.
say that.
um, so you're there, and so you start nursing, and you guys always lived on the farm.
No, we live in a neighborhood and I have never lived on a farm,
You have a
but
farm.
my life looks like I live on a farm.
It definitely does. Is it?
Um,
That's a neighborhood.
it is, but I lease a farm to keep my horses on,
Oh, okay.
and it's only 5 minutes down the road.
Okay. All right. So it looks kind of like when you're posting it on social, it looks close to your house.
Yeah.
Um, so just so everybody knows, I've never been to Ruth's house, but she was always coming in with various things that would have appeared to come from a farm, like beekeeping related paraphernalia, stories of her bees, stories of her honey, pictures of her family on horseback. So I just pictured you on a farm, and you had also lived. I think you revealed to me you lived. And Virginia, the area around the hospital is unique for this. It's close to Washington, D.C., so if you head east, you're very quickly in a very urban city setting. But if you head west,
So true.
generally speaking, it doesn't take
You
long.
can
You're
get to
very,
the rural.
very rural pretty quickly. So a lot of the people that we worked with there, you'd sort of have half the folks coming in from the city commuting east to west, and the other half living very rural lifestyles, commuting west to east. And some people commuted really far from way out
Yes.
rural. Yeah. Um, that background, horseback riding, beekeeping. Have you always done that? Did you pick that stuff up when you moved to Virginia?
My grandfather was a beekeeper, and
Uh,
when I started nursing orientation for the operating room in 2015, uh, I also picked up beekeeping again because it was a family tradition.
huh.
And the one place that no one will bother you is in a bee yard.
So this is like this is a pro mom tip for
Yes,
anyone with four
yes.
kids. Yeah. Pro mom tip,
I
everyone.
did.
Start
I did rope my.
beekeeping.
I did rope my kids into helping me with it, but they quickly lost the appeal.
Ah. Why? Are the bees scare them, or?
Um, it's hot, and I've cut down. I used to run 5 yards, and I cut down on it. It's a lot of work. It's a lot of heavy lifting, and I just told my family yesterday that I'm not going to keep that many beehives going through this year. I really want to focus on my horses,
Mm,
and we're going to move the. It's just a tweaking here and there.
tweaking. So you did. So you knew it from your grandfather, and picking it back up was not hard.
No,
If you had a neighbor, like a rookie, how long would it take someone to learn to be a beekeeper, to learn to keep bees on their own?
I would say about 2 years
So it's that involved.
because you have to go through the entire year cycle, and then
Uh-huh.
you have to figure out what you did wrong the
Mm.
next year.
Okay, that's pretty fascinating. And then horseback riding, you were always involved in horses, or since you were a kid, or you got involved later in life?
Probably more in as I was a kid, I was exposed.
Hmm. How did you get exposed as a kid?
My father would take us horseback riding on the plantation where we lived near, um, and I started there.
And then when when in your life did you start owning horses or having horses that you had to care for?
Well, I bought my daughters a horse each, and that was the beginning of our journey. I didn't know what I was doing, and I would never recommend it, but I was leasing another horse from somebody, and I felt like now's the time.
Huh.
And then thankfully, I parted with that person and uh, made good faith arrangements with my landlord at the farm, and she has been really good to us,
To keep the horses
and I've
and
learned a lot.
yeah, I'm sure. So you did it as a child. You were exposed as a child. It was meaningful to you when you had your daughters. Somewhere in that relationship, horseback riding became important, and you said, you know what, let's get into this as a family, and we'll actually get horses and keep them close by. And is
Right.
that about right? And from Facebook, there's you looks like you guys are regularly on the horses or with the horses. They seem like a big part of your life.
Yeah.
Yeah.
Well, you have to be out there a minimum of twice a day, and then if you're taking lessons, which I do have a personal trainer, uh, it's more. And then we are trailering my one horse to event training, and my trainer's riding her, and I'm riding the black one.
And the kids, how old were they when you started them riding the horses?
Like 14 or 15,
Okay, so
and
they were.
now they're 21 and 24.
Whoa, wow. Yeah, that's you asked me that question earlier. With my guys are 10, 8, and 5 now. And
I can't even imagine.
when I left, I know that I just had the 5-year-old, so he was a brand new baby, and we packed him up and moved with him, and that was a ton of fun. Um,
Oh yeah, I
and your
bet it
guys
is.
were, you would show us pictures. I don't know if I ever met any of your kids at work, but they
No,
were teenagers and tweenagers, and now they're adults. That's wild. Uh, so they ride
kids
with you
make us
still.
old.
Yeah, kids make you feel old. Um, so you have this like, I mean, this is the other reason I wanted to talk to you, Ruth, because I think from a patient standpoint, you've got all these interests, and so you've got this sort of engineering mind. You were in IT, but you felt a connection with people, wanted to do something in healthcare, made that happen at the time you were raising a large family already. Um, you have interest, the hobbies with beekeeping and the horses, and so you've had this very full, busy life. Probably people listening to this are like, "How in the world can you do all these things?" I know I'm thinking that.
Family support.
Yeah, yeah. Um, and so you start in the operating room in Inova, and do you like it? Do you like that transition? Because that's the first
Oh, I
like
love
full.
it.
You loved that. Okay, so you were happy. You graduated. You were like, hey, I thought I
Yes.
made a mistake. Found the operating room nursing role, and now you're like, I'm having fun at work. This is great.
Yep.
Yeah. And then, um, so at that somewhere in there, and for the audience, we haven't really talked about this yet, but and we'll kind of make a little intro plug where we give a little background on you and give the framing of the discussion. But obviously, you're diagnosed with a brain tumor during that period, and
Right. It's
wh-
your fault.
and that's my fault due to stress. But which obviously, for anybody who doesn't know, if you have a brain tumor, that's going to be picked up on imaging like a CAT scan or an MRI, but something needs to trigger the quote workup or the reason to go see the doctor, the reason to order those studies. Do you remember, Ruth, like you're working in the operating room, you're riding horses, beekeeping, busy with kids, busy with family. What was it that kind of made you say, I'm not feeling right. I think I need to see somebody.
Um, I got really angry,
Huh.
and I quit my job, which was unlike me, but I was having trouble with the administration, and there was just one person that I was really having trouble with. And
Was that me? We can
was
say it
it
on the
you?
podcast.
No.
Yeah, okay, good.
I don't want to say her name.
No, 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 of
Um,
course not.
but yeah, I was getting angry, and I remember mentioning that to my surgeon who came to sit and get paperwork signed. Like, maybe this is why I quit my job, because I loved it. I loved the adrenaline. I loved everything about it, even the stress. I was really happy with that too, which is really odd to say, but I liked being on the cutting edge of technology. I loved what you were doing, and I didn't mind coming in for your days because 12 hours in a room with you.
So, for anybody listening, what Ruth's talking about is, first of all, I think, and you can speak to this, Ruth, anyone who's thinking of nursing in the operating room, it's just it's a real time environment. I always relate it to kind of like a sports team or something. Like, it's active. It's a
Right.
dynamic scenario. It's someone's life is on the
Very.
table, and so it's not really you're not sitting around holding a meeting. You're in there
No.
actively engaged, and it can get very intense, especially if anything were to, God forbid, go wrong. And in the room is a patient, an anesthesia member, which is either an
Right.
anesthesiologist or a nurse anesthetist. There's an what's called a scrub nurse who's gowned and draped and part of the operation handing instruments back and forth. And then there's what's called a circulating nurse who is moving around the room, assisting in all these activities. That's like the core team. And at least when I was there,
And
Ruth, you
scrub
were,
techs.
and scrub techs. And
Hmm.
yeah, that's true. There can be other people in the room, but that's sort of the core team. And when I was working with Ruth, she was mostly circulating and in the room. And so I guess back to so you were doing that job. Yes, it was stressful, but you kind of liked the
Loved
stress. You
it.
like being part of the moment. And then you started to notice you're getting super aggravated at this administrative person, and that's just not, something's not right. Like, that's outside your
Right.
character, but you don't recognize it right away.
Yep.
You quit the job out of frustration, and are you at home
Sort of, yeah.
saying, That's weird. That was weird. Maybe I should go to the doctor?" Or how did that translate to
I
getting?
had texted one of our surgeons, and
Mm-hmm.
I asked him, if you had a person presenting with these symptoms, uh, what would you recommend? And he said, you need to go to a neurologist first. And then the next weekend, I was at the ER because I had gone to my bee yard instead, and I was cutting branches, and I cut my finger.
Okay.
And I could see it happening, but I could not respond. And my I had also had a doctor's appointment, which was virtual because this was at the time of COVID.
Hmm.
Uh, and I said, I I think my blood pressure is a problem, and I took it, and it was 179 over 130,
Whoa.
and I was like, holy crap,
Yeah.
because I'm normally like uh, 120 over 65 or something.
Yeah.
And I sent that to my cousin, my niece, who was also studying to be a nurse. And I said, what would you tell a person with this kind of blood pressure? And she goes, you need to go to a stroke center or something. And
Mm-hmm.
I'm like,
Okay.
that's what I thought. So it's like there was a coming together of all these things. And I'd already talked to a neurosurgeon. And then I was in my bee yard and I cut my hand. And the person who was, and then I became aphasic. I couldn't even talk right then. So they took me to the ER, Cornwall, and they had to strip me out of my bee suit because I'm holding my hand. I had cut it close down to the bone.
Oof.
And I was just, I couldn't talk. I couldn't do anything. And they're stripping me out of my bee suit, which is covered in blood.
Mm.
Uh, and then the person who was with me said, and I credit him with saving my life. He said, I don't care about her hand. I know she needs stitches, but you need to check her head. And so they put me in the CT scanner, and I discovered the mass, or we discovered this mass in my head.
And that might be that might be important for people to hear too. I mean, depending on where a lesion or a tumor in the brain is, it can be in what we call eloquent or non-eloquent cortex, which is the outer area of the brain typically. If it's in a non-eloquent area, you might not even know it's there, because non-eloquent
Right.
generally refers to areas of the brain that are involved with processing. They're not immediately involved with motor function, executive function, or speech patterns, either understanding
Right.
speech or making speech. So you can have a brain tumor or lesion in a non-eloquent area and have it grow for quite some time. And typically what brings those patients to the system, to a physician, to an ER, whatever, are symptoms related to the pressure inside the head, because this thing has grown to the size it's grown to without the patient knowing it.
Right.
If instead you have a tumor in what we call eloquent areas of the brain, you'll start to notice dysfunction either slowly, or you're almost a combination. Or it sounds like you were almost noticing some elements slowly, but maybe not recognizing them, and then all of a sudden there's sort of an acute precipitation, and you're not talking, which is aphasia. If anyone doesn't know that, it means you either can't understand speech, so you talk at a patient or a family member and they're not understanding, or if they have what's called an expressive aphasia, they're trying to speak and
I was trying to speak.
either no words are coming out or garbled speech is coming out.
Yeah.
So those folks, if you have a tumor in an eloquent area, you can present either with a progressive history. People say, I've got this weird numbing and tingling in my arm, or I noticed
Right.
I can't all of a sudden can't move my foot, and that can be from the motor cortex, and the speech issues obviously from involvement in the speech areas of the brain. So you sort of, correct me if this is wrong, Ruth, but you recognize behavior changes, and you enough to kind of text some people that you knew, because you had text access to colleagues who work in the neuroscience, neurosurgery space. Said, hey guys, what if someone had these issues? And they'd say, yeah, you'd probably see a neurologist. You were either planning to do that or never ended up doing that right away, and then you're out keeping bees and you cut yourself. Do you think you cut yourself as a result of not functioning normally because of the tumor, or was that
Yeah,
like
for sure.
Yeah, for sure, yeah. And that brings you to the ER. When you're in the ER, you're not able to speak, and it's clearly a bigger
Yes.
issue than just a laceration on the hand.
Yep. And then I was in surgery 2 days later.
That's fast.
It
And
is
for
fast.
anybody, go ahead, Ruth.
You go ahead.
For anyone who doesn't know, a CAT scan is sort of a verified 3D X-ray of the head. Most hospitals and emergency rooms have one these days, and it's a very quick study. It takes 10 minutes to get, and so that's typically a screening study, especially in an emergency room setting, for strokes, brain bleeds, brain lesions, anything to just take a quick and dirty look at the intracranial
Right.
space, basically. So what Ruth is describing, someone clinically in that setting realized she's not making appropriate speech, which immediately makes you think neurologically of the brain space. And so part of the workup, of course, is to stop the bleeding in the hand, but once that's taken care of, is to get what's called a stat scan of the brain to look for stroke or what's causing this speech impediment. They do that, and then since it is a quick and dirty look, you see typically you'll see a sort of a fuzzy area that looks consistent with a mass is kind of the way we'll word it. But you need a more detailed study to confirm that's what you're looking at, which is usually what we call an MRI. And I'm sure you went and had that promptly, Ruth. Yeah.
Many MRIs.
Many MRIs. Yeah, many MRIs later. And so this is a quick turnaround. So they in the ER they realized that. Do they admit you straight away because of this finding?
Uh, I was in Leesburg, and they put me on a transport and took me to Fairfax.
Okay. Which is a more tertiary hospital, which is common
Level one.
if anybody is dealing with a family member or themselves having something like this. Most health systems are set up with a sort of a hub and spoke model. The cranial issues are very complex issues and aren't typically dealt with at local community hospitals, so you're typically filtered into what we call tertiary referral hospitals, so sort of the main hub, if you will, where
Right.
the technologies and teams that are needed to take care of complex issues like this are co-located. And so, is your family with you in the ER, Ruth? Like, somebody took you there, right? Is it
Yes.
one
Yes.
on alert at that point, or are phone calls going out at that point, like panicked phone calls? I'm sure.
Yes.
Yeah.
I called my siblings. I called my father. By then, they had put me on Dex, and I got the swelling down enough to be able to talk.
Yep.
So I was
Dex.
calling people.
So that's an interesting point. So if anyone has to, if anyone has to deal with this, as the tumors grow, if you have a tumor, it starts small, it grows bigger. The brain around it, it's different than a stroke because it's not typically destroying brain, but it is pushing on brain. The brain around it can get very angry and inflamed. The dysfunction is largely from the pressure and from the swelling in the brain for the most part. There's more subtlety to it. You can get infiltration of the brain, obviously, but at least initially, a lot of the clinical manifestations are coming from swelling and pressure. What Ruth said, Dex, is dexamethasone, which is a common steroid used to reduce brain swelling. So oftentimes you'll find a patient like Ruth, unable to speak, a little bit of steroid takes some of the swelling out of the brain, and then that tissue starts to become functional again. It's usually surrounding the tumor. It's still intact tissue. It just was dysfunctioning because of the swelling. Once the swelling's out, patient will improve. So as Ruth said, she starts being able to talk again. And then for anyone trying to imagine that, if you can't speak and then all of a sudden you can speak, I think we'd all be on the phone sort of trying to communicate to everyone we can so that they come, because you're probably fearful that you don't know when that'll end, right? When you won't be able to speak again.
Well, that's a terrifying moment. So,
Yeah. Yeah, I can only imagine that moment. And maybe that's a point people would want to, I think one of the reasons to talk with you, Ruth, is people go through this, right? And if you're going through it or your family member is going through it, it's terrifying. And this is years in the past for Ruth, and she's been living a very fantastic life after going through all this terrible stuff. Can you speak at all to, do you have any advice for people who may have just found out they have a lesion in their brain? And I'm sure all the terrible thoughts that everyone would have with that diagnosis are running through their heads. You've been through
right.
this.
I wrote a frequently asked questions 2 years ago. And I can actually pull it up, which is the benefit of us doing this separately.
Yep.
I said, you got to change your attitude. You got to change your way of living. You got to change your way of eating. Your stress levels need to come down. What else? Change your life. Nothing is worse than getting cancer, and especially brain cancer, but now I look at this as the best thing that happened to me. You have to own your own decisions and own your own care. For the details, I described what I had. It was a left frontal temporal tumor, and it was 2.5 by 3.5 centimeters. just off the dura, but there was a deeper shadow on my MRI, and so this became the second tumor.
Mm. So, and you knew
And
that
then, go ahead.
you knew that that MRI, those MRI results came back to you after the CAT scan. So you're kind of, you go to CAT scan in this wild situation where you've got bleeding
Yep,
hand, you can't talk, they rush you down there, so very kind of intense. They see something, they send you to CAT or MRI, which is a magnet-based image. It takes longer. You're in this funny tube. It's very loud. It takes roughly an hour to get the
it does.
picture taken, and then you're
Yes.
waiting as a patient for the radiologist and the team to kind of evaluate and analyze the images. So in the interim, Ruth is given the steroid. She's able to speak. She's calling family. And then at some point, the team that's going to be taking care of her has to discuss with you the MRI findings. So
Right,
I'm assuming at this point you're admitted into the Inova hospital, and
right.
you,
It
with
was a
your
Sunday.
background, you know, you've worked in neurosurgery, so they're probably showing you
Hmm.
images, and you're seeing all this for the first time.
Yep.
And when did you write that list, Ruth? That was obviously, that takes time to process.
Uh,
And
2021 or 2022. Let me go down here. July 9th, 2022. And I've been kind of tweaking it, but the first thing I said is you need to get genetic profiling. I recommend some books. I actually sent, during that process, I sent a link to my surgeon and I said, I want you to watch this. And it was, the link is survivingterminalcancer.com,
hmm,
and it's a free movie online. And that's where I started when I got out of the hospital.
mm-hmm,
I started perusing PubMed, and by perusing, I mean putting some hours in on it. I was like, I am going to figure out how to fight this because the results are so abysmal.
mm-hmm,
And I did a lot of things. Within a week, I had something called black seed oil in the house. And I was taking that. I had my mask made at Inova before I got accepted to my NIH trial. And then I had to go have it made again. So there was like almost 7 weeks between the surgery and when I actually started SOC, which is standard of care. And in my trial, I was using selinexor, 4 doses of that. So between that time, I was taking other things and trying to attack what was left of the tumors and heal myself up. I took a lot of different things, and I recommend people take some of that stuff. Don't know how to put this. You have to own your own care. When I watched you talking to Dr. Grunch, was that her name?
yep, mm-hmm,
She was like, well, the people over here in this strata of socioeconomic um, means are different from the people over here. And I'm like, I understand that completely
mm-hmm,
because my mother recently died and she had white coat syndrome.
mm,
And the moment I got on the phone with her when she first met her doctor, and I was on a conference call, and I knew that right then she was going to die because she was not uh, proactive. She didn't ask any questions, and I was trying to ask questions, but I got shushed.
mm-hmm,
Um, so the thing I think about with glioblastoma is that you have to chart your own course, and if that includes other things, including standard of care, because I don't know of anyone that survived without having um, resection and radiation and chemotherapy. I do know of people who have survived this for 25, 30 years.
Hmm.
And those are the people I want to pay attention to.
Hmm. This was so for anyone listening. One of the other reasons I really wanted to talk to Ruth was, like I mentioned earlier, she's very open with her journey on social media and living such a good life with the diagnosis. But also, I noticed from a distance, because at this point I'd moved away, just on your social posts, Ruth, like how much of a um, what you're just describing, like how much effort you put into finding the latest information and
Greatest.
finding every yeah, and traveling for the greatest kind of opinions. And I thought that was really interesting for people too. And I'll just drill down here a little bit, because I think, at least as someone who works as a neurosurgeon, I think we leave the patients, and you can speak to this, Ruth, feeling kind of like not fully informed, right?
Oh, yeah, we're not informed.
Yep, yep. For anyone listening, if you happen to come down with this, with any brain tumor diagnosis, like we were describing with Ruth, you get the MRI, and then sort of standard of care is to have surgery to remove the lesion, and then also to have usually radiation therapy and chemotherapy or immunotherapy. So some type of medication you're getting, and then some type of radiation. And unfortunately, each one of those is given by a separate specialist. So your surgeon is a neurosurgeon. The individual giving the medications,
Neuro-oncologist.
yep, the medications of chemotherapy and or immunotherapy is not just an oncologist, but a neuro-oncologist, so sort of a subspecialized individual. And then when you sit in a little machine and get radiation to the brain, that's delivered by a radiation oncologist. So all patients will have sort
There's
of
a
three,
whole circle.
yeah, a whole circle of people around them, and it can get confusing because I think where some patients may have a bad experience is no one's really quarterbacking. Each one of those roles is
Right.
equally important, and that role of sort of quarterback where the system, the healthcare system, provides the patient with all the information they need is not totally there all the time. There, don't get me wrong, plenty of places where everybody does a great job and patients feel 100%
Right.
informed. I'm not saying that's true, but um, and then Ruth gets the diagnosis of glioblastoma, which she just mentioned, has a very poor prognosis when you look at everyone writ large, and I'm sure is a defeating diagnosis to get. However, to her point, if there are folks that are outliers and have very long lives after that, and there are a variety of different trials, clinical trials ongoing, and things like that. And so that might be a great point, Ruth, because this is where you dug in big time and advocated for yourself, and people may not know that they can do that or know how to empower themselves to do that. So you go through surgery, you're getting chemo, radiation, you've got the team, but you're a nurse. And what, if you can remember back to then, do you start conversations with your team and say, look, I want to know, are there clinical trials available for this? What else can I be doing
Um,
for this? Do you dig into social media, patient platforms? Like, where do you go to empower yourself?
I did dig into Facebook forums. I did dig into there's Cancer Commons and other things out online. I reached out to people. I reached out through different like Chris Beat Cancer, and I talked to everybody on that platform that I could find that had GBM. They have amazing results, but you know, if you're dead, you're not going to be talking.
It's not like anyone made a clinical error. You wanted this framed differently. You wanted a different attitude behind the approach. And so
Absolutely.
how did you, when you said, you know what, this team's not my team, how did you find the team you ultimately stuck with? Because I don't think
Well,
people
a
even know
doctor,
they can find their team.
well, yeah, most people don't know that you can fire people that's on your team. Uh, I had someone come to me through a different channel and say, hey, there's this study going on and there's a trial, but it's a very difficult time to get people to sign up for that trial, and I was patient number one. And I loved being there. I still love it being there. I've already graduated from the trial, and it's been really good.
Was that trial, Ruth, testing? I don't know how much you can disclose, but was it testing a specific chemotherapeutic agent or immunotherapy agent or protocol?
It was a radiosensitizer called selinexor.
Okay, got it. So, and in that journey, so what for anybody who's a patient who might be listening, we sort of brushed on this, but if you have these tumors, especially GBM, and I think we're kind of focusing with Ruth on GBM because that's her diagnosis, which is the most aggressive type of brain tumor. It is a cancer. It is malignant, and we'll go back to kind of what we were already talking about, prognosis and what that data is. But what Ruth is describing, that comes out with surgery as a first step, and then focused, what we call stereotactic radiosurgery, which is radiation to the tumor bed or the tumor area in the brain, which is very focused. In the
Right.
old days, that was sort of typically whole brain radiation, which there are side effects from.
Yep.
Now we do a very targeted, focused radiation that's very precise. And then medicines, like I mentioned, standard chemotherapy and immunotherapy drugs. With
Which is
that,
temozolomide.
temozolomide. With that protocol, unfortunately, when you look at large numbers of people, it's still a very deadly disease. As
Right.
such, as a community of physicians and providers, we understand this is not the goal, right? The goal is to find a way to cure this. So there are
Right.
a number of clinical trials going on, and for anyone who's a patient, check out the podcast with Dr. Mills because we kind of go through the different phases of research. She's very much, that podcast was with an investigator, a scientist doing bench side research.
Mhm.
They make a discovery, typically in a petri dish. They move it into a mouse or small animal model. If it shows promise
Right.
there, it has to go through the FDA and get approved, and then it enters patient-based clinical trials that are done in phases. And
Right.
because GBM or glioblastoma is so deadly, there are a number of clinical trials going on looking for agents that can have success for patients like Ruth. But you do have to typically seek them out to some degree. Your team should point you to resources to review these, but the patient becomes very active in this process because not all trials are
Or
actively
not.
or not.
Yeah.
Not if you're interested. Yeah, it's a good point. If you want to take that step, you can be a very active participant. Not all trials are actively enrolling. Like Ruth mentioned, some trials complete and they'll process data for some time. So it really depends for each patient where you are in the journey and what trials are currently open. And then Ruth, how would you talk to people? Because part of being in a trial is these are scientists investigating a medicine, so you have to agree to be, quote, a test subject.
And I
Was that
did.
okay
Yeah.
with you? Did you feel comfortable with it? Were you excited or was it
Oh, heck
scary?
yeah.
Yeah, okay.
No, I was not at all worried about it. What I'm worried about is dying. And with 4 kids, you know,
Yep.
and so I was worried about that. And I want to see my youngest get out of high school.
Mm-hmm.
And he's
How?
got couple. Go ahead.
No, go ahead. How many more years does he have?
3 years.
3 years. So your immediate goal, not to diverge here from because I think it's really interesting how you fired your neuro-oncologist, got into this clinical trial. You brought up your son and that being the next goal. Is that how you're living life? Are you doing day to day, or are you setting goals like that where you say, okay, I made it to a year, I'm making it to 2 years, I'm making it to 3 years? Or do you put the goalpost further and say, no, I'm making it till my son's out of high
My
school?
my minimum requirement for me, this sounds like really crazy, but I want to see him get out of high school.
Mm-hmm.
But now my daughter just announced that she's getting married. I'm like,
Yeah.
ah. that moves the goalpost
You
further.
move the goalposts. Yes.
Um, yeah, and it's not like I'm looking for a chance to die. I don't want to die. But I realize that as you go along, you have these things in your life that come, and it's the life experience that people can miss out on. And I want to have that experience and have a full life.
As a provider, you'll see a lot of people, and I can't say this wouldn't be me if I faced something like this. The fear can be crippling, and when I
It can
watch
be.
what you do, Ruth, it's like you haven't been slowed down, at least from I'm observing from afar. I realize I'm not in your everyday life, and obviously there are struggles, but
Well, I can tell you what we did first.
yeah.
I I got the call from my surgeon, and he told me, with all my kids around, what the diagnosis was. And one son was upstairs, and the girls went up to tell him. And I went over to my youngest son, and I said, "What do you think?" And he said, "I have a good feeling about this. That's my baby."
Mm-hmm.
And then my other son came down, and we had a little cry. And that was it. I closed off the world for like 3 or 4 days, and I started thinking that I need to find out what are the options, what would help me. I don't care what people say or think of me. I'm going to find what will work. And I called my sister that day when I finally made up my mind. And she said, "Well, you're not talking like you were the other day. You are now seem motivated." And I don't know what all she said. And I'm like, yeah, I got backed into a corner and I came out swinging. And that is typically my MO.
Right. Right. Yeah, that tracks. Um, Thanks for that,
And
Ruthie.
how
I
does
think
that track?
I didn't mean anything by that.
Oh, you're
So
lying.
when I worked with Ruth in the operating room, I was scared of her and did not want. She was someone you knew you did not upset first thing in the morning, or last thing at the end of the day. And there was just sort of this stern stare that would come across the room, and you knew you'd crossed a line, and it was not going to be okay if it was Ruth.
You know, you and another doctor at the Innova team, I had to back up, and I love you. Don't take this the wrong way. I had to back up and text a home and say, if I quit my job or get fired today, are we okay? And the resounding answer has been yes. And I don't think most people can take advantage of that. But you and another doctor made me do that once each.
Can we cut that out? Yeah, that was. I'm sorry, Ruth.
No, you remember when we went out in the core and I was like, I want to throat punch you right now?
Yeah, I think that was a direct quote, and I remember thinking. So this is a total aside, but I had alluded to at the beginning of the case. Ruth had to deal with me personally when I was coming out of training, and that's this. It is this very. For me personally, I think other surgeons
Very
would reflect on this too, but it's very stressful, and it's a big transition in the
tumultuous.
training for us.
Yeah.
And it
Yeah.
goes from hand holding and sheltered to kind of captain
To
of the
being
ship
on your own.
kind of thing.
Yep.
And people deal with that stress in a lot of different ways. And for many of us, it can be you're very tense, and you're not always dealing with people as your best self. And Ruth is someone who tells it like it is. So I remember having a real like sort of an exhale moment. So we went out, we had gotten into some type of terse discussion about whatever had gone wrong in the operating room. We went out in the hallway,
Microscope.
and she said, I want to throat punch you right now. And it just opens up a space to like exhale on my end. You know, it's kind of an honest discussion rather than what can happen in these settings, which have become, in my opinion, sort of overly corporatized, where
Yes, they have, which
HR
was
has
another
become
reason.
more and
Hmm.
more of a presence in these environments, and you can't curse and you can't, which is good. On the flip side, it's a stressful environment where if you bottle stress up, that's
It's going to
bad
explode somewhere.
too. Yeah, so like the ability to have colleagues where if something is stressful or God forbid there's a complication, developing relationships professionally in a way where the team knows how to deal with the stress and de-stress one another is a complex thing to do and develop. And
Yeah.
I don't know that there's a science behind it. For me personally, it's happened with people like you, Ruth, with those types of conversations, right? Where it's like, where's the line? Here's how nobody crosses this line anymore. Here's how we deal with stressful situations and how we communicate to one another. And that's going to be, I don't know if there's a science behind that. I think that's interpersonal for each and every team out there. But for anyone who deals with these types of issues, it's about my mistakes in those days were letting the stress overwhelm me and not being my best self. And what I learned to do over a little bit of time is, if that situation doesn't arise commonly at all anymore, because the stress goes down the longer you do the job and know all the different ins and outs. But if
Well, I
something did
hope Kelly
occur,
has helped you by getting you to put your feet up.
put your feet up, yeah, put your feet up, relax. I started walking away. You know, if you ended up in a stressful situation, I learned to just sort of walk away. If the stress gets to be so much or you're so frustrated, just walk away from the situation, take a small break, which sounds silly, especially in an operating setting. You'd think, how can you do that? You can still do that.
Yeah.
And that can allow you and team members to have a less heated interaction, because no one's thinking right if everyone's upset and heated.
Right.
But not everyone feels empowered to put people who are having those moments in their day in their place. Ruth's obviously someone who would happily put me or anyone else in their place. Not happily, maybe, Ruth, but and you need that.
Oh my gosh.
All of us will need that at some point. And so that was Ruth and I had a great, I think, you can comment otherwise, Ruth, a great working relationship for that reason. But when I reflect back, it's also, that was super stressful. And
It
I think I
was.
talked about that a little bit with Dr. Grunch. Like, there are areas in healthcare where the mentorship just sort of falls off. Do you need?
Right.
Yeah, at some point, if to make an analogy to flying a plane,
The
like a
same for
pilot has to.
everyone.
Yeah, and you have to fly the plane yourself at some point. However, there are ways to support people through that. And if I had to
Right.
support someone through that at this stage of my career, there are a lot of things I would do differently than have it be the way I went through it. Separate conversation, but nevertheless. But yeah, Ruth told me that she wanted to throat punch me.
And you had
I
on
totally
a thyroid
appreciate.
collar.
And I had that's right. And I was wearing an armor to protect me from that if it came to it. So I wanted to go back, Ruth,
I think it was diffused well.
Oh yeah, I thought
We got
so.
it done. Yeah.
Yeah, I thought so. Because sometimes people won't. And this isn't for everybody, and this isn't really a comment on how to handle these situations. I'm no expert. I always found for myself, and this goes to many different interpersonal spaces, but I always appreciated, as opposed to being passive aggressive, someone like Ruth and I'm the same way. I would describe as just straight aggressive, right? It's like, there's a problem, we're going to step outside and discuss the problem. It's very upfront. And everyone I've ever dealt with in that manner, we discuss what needs to be discussed, and then those types of people, it tends to be water under the bridge, right? Like, everyone set their boundaries. We had a adult conversation, and you're able to move past it and still have a good working relationship. Where this
It
is
creates
reflecting back
stories.
to that, like the over corporatized version of this sort of sublimates all of this energy into a passive aggressive environment, and passive aggressive energy doesn't go away, and it gets really sticky and difficult to
Poisonous.
work in,
Yeah.
because people aren't empowered to just say, you know what, I'm having a frustration with this colleague. We need to have a big boy, big girl conversation. That's become especially now, with the politics in the air, I would argue that's become more difficult,
More difficult.
which is challenging, especially for teams like operating room teams, where this is a real-time stress environment, and those kind of conversations keep people respected, and they allow that pressure to diffuse. It's a release valve, and it's
Right.
when it's done respectfully, it's done. I think there's a professionalism in that. There can be. And it doesn't have to look like something that's appropriate for an HR boardroom, in my opinion, right? Like, we weren't doing this, Ruth.
I don't want to involve other people.
Right. Like, we didn't end up doing this, but I think if, with our specific relationship, if we had ended up in the hallway sort of cursing at one another, and someone walking by might have said, "Oh my God," it's not necessarily bad. We may have still walked away and said, "Good, I think we both." It's a very personal thing how the two people relate to one another.
Right.
And I work continuing to work in medicine as it becomes more and more corporate. This is handled more and more sterilely with this very much HR kind of
But we're
vibe to
not
it.
sterile people.
It's very
People are
bizarre.
not, people are messy.
I actually had this thought. Now we're getting way off track here, but it doesn't matter unless you have a time commitment that you need to get. Tell me when to stop
If you
talking.
don't mind, can you hear other people in the background?
Do you guys hear anybody? No, we don't hear anybody.
Okay, great. Because I have someone across the hall that's talking on his meeting, which is why I didn't want to do it here.
Don't hear it at all.
So, great.
Yeah, we hear nothing. Yeah, so I thought about this when the Super Bowl just happened, and there was that picture. It kind of went viral of Travis Kelce, and he went up to Andy Reid, the coach on the Kansas City Chiefs.
Yes. And
And it was
jostled him up.
and it was sort of this like ugly moment, and people had been kicking it around on the mainstream media and social media. And I've always made the analogy from the operating room to a sports arena because of that real time element of it. And it's like trying
You
to
cannot dissect it and sides and backseat quarterback.
right.
Yeah,
It's
or
too-
whatever that is
It's
called.
too in your face. It's too in your face. That said, there's still clearly behavior that is pathologic and abusive. I've seen abusive behavior in an OR, and
I have too.
that's not okay. So it's this it's trying to thread a really tight needle for sure. Anyway, sorry, Ruth.
So I had a question for you.
Yeah.
I'll get back to the topic at hand. Um, what would be your first response to being diagnosed with GBM?
I don't even know if I could answer the question. I
I was
honestly,
thinking about it this morning.
yeah, I don't know. I have no idea. I just had a funeral for my aunt who was very close to me, and she had leukemia as a teenager and survived, but back then it was whole body radiation. And so in her later years, whole body radiation is not obviously very focal or specific. So in her
Right.
later years, she had a lot of secondary cancers that were from the treatment in her teenage years.
Right.
So, in her journey, she was very religious, and she was just always very positive, always a a loving person, always a giving person throughout all these kind of challenges. And I was at her funeral and sort of listening to the eulogies and thinking, like, this woman has had
Is that
cancer her whole life in one, almost her whole life in one form or
right?
another. She's been dealing with this. And, I grew up with her, and I don't have one single memory of her as stressed, of her as unkind, of anything. I mean, she was just a glowingly positive human being throughout all of it. And that's maybe one of the reasons I asked you where you get your strength from, because I don't think any of us know how we would truly react if we were to get news like that. But when I look at people like you and people like her, I guess look, we all die, right? Unfortunately. And I
Right.
think
Nobody's
while
getting off this
you're
planet alive.
right, yeah, no one gets off this rock alive. And I think as a provider, our patients, as a family member, our family members, friends, colleagues, you're teaching us all how to do that with grace. And we may not all be able to live up to examples like my aunt or like yourself, but when I see people like you, I think in my head that's what it should look like. That's if I had the strength, that's how I would do it. I think to stay positive, to stay kind, to not get overwhelmed. I can't say I would be able to do that. I don't, the stresses seem unimaginable to me, but I see people like you and her doing it, and it's jaw dropping, frankly.
But it's not about religion or not religion, because morality comes in different phases and forms. Uh, I just think you have to put your mind to it.
Yeah. I think that's an interesting point with your list from earlier, Ruth, where I'm sure for me, if I got that diagnosis, it would be a massive reorientation of
Yes,
priorities and
it is.
perspectives. Some of these conversations through the podcast, through practice, I've tried to recognize that, what the common phrase would be, look, no one on their deathbed would want, more time at work or more, these kind of common reminders throughout
Right.
life. And from talking to folks like you, it's like, is there a way to sort of approximate that reorientation that happens for people when they're faced with these problems? Can you do that in your everyday life? Why do we seem to need a disease or a diagnosis or some life event to say, whoa, I'm misprioritizing things. I need to focus my
Yes.
energy and time here. I guess you'll hear that too, live every day like it's your last day. Just, do we all do
But
that
who
every
does?
day? No, we don't
Yeah,
do it.
it's hard.
It's very difficult. But whenever I have these kind of conversations, I will say that about healthcare, we're part of the journey is dealing with a lot of difficult conversations and having patience and people you get close to deal with difficult issues. One of the unintended benefits, I think, is a constant reminder to evaluate your priorities, because that reality is kind of, you're faced with it on a daily basis. Not personally per se, but you're reminded of it through your patients and your family.
I was reading something, uh, I think it was in Al Musella's book that he put out with Henry Friedman,
Hmm.
which is about GBMs. And
Okay.
there was a patient in there that got GBM at 23 years old.
Wow.
And he decided that he wanted to make his life meaningful. And he went into healthcare and became a physician. I think that's how it went. And that made an impact on me because I want to go back to the OR, or I want to make meaningful impact around people, but I think that my place is not in the OR anymore.
Yeah.
It's one-to-one and helping people. And I do that throughout my days. I talk to people in like the Netherlands and Italy and a lot of different places. I've got this huge network now,
These are
and that's
through
how I. Hmm?
your networks through sort of patient forums and things like that, Ruth, or where is that coming from?
Uh, People find me.
Hmm. Because of your social posts? How do?
Yes.
Yeah.
Well, in forums that
Forums.
I have participated in, and
Yeah, that's a, and I guess I'll get back to where we were before, but that's, I already mentioned this, one of the reasons I thought you'd be a great person to talk to about this. As providers, we lose track of what, patients go home at the end of the day, and this sort of network of support and investigation
doesn't
that
exist.
yeah, right, it's not formalized, and it people do
No,
it
and
on their own.
yeah, and what has happened is that I have reached out and found people and found people and found people, and through those connections, other connections have grown, and it's just it's been eye opening
Mm.
about how many people need a protocol to follow, not herbs, not drugs, not repurposed meds. It's just the network of friends that you can create.
Yeah.
So,
Is and is I mean, I'm sure there's an element of like, is everyone you're connected with, Ruth, a GBM patient, or is it grown to
yes,
beyond? So it's a GBM community, basically.
yes.
Yeah, and no one with another diagnosis has ever reached out or wanted to kind of
Oh,
co-discuss
yeah,
things. Yeah. Okay.
yes.
Yeah.
Because
Okay.
the other thing is, one of my horses has melanoma,
Hmm.
and I sent a tumor out for her to be made a vaccine. And I gave her the vaccine. So I won't know if it works or not, but I was willing to try it. And from that, I understand the immunological aspects of this. I also understand the repurposed meds aspect of this. And
And what is that, Ruth? I'm not familiar with that. Repurposed meds.
you're not?
Mm-mm. Is that a way
Okay.
for? Yeah, go ahead. Sorry.
Well, there's an entire community out there, and it's led by Jane McClellan. And she promotes the use of repurposed meds. And when you go to PubMed and you type in a medication or something, a supplement or an herb or whatever, you can find all this information. And that's how I found black seed oil, and I started there. And I was like, wow, there's a lot of things out here that can attack GBM.
Hmm. And that phrase, repurposed meds, is a medication
Like
that's
using
out there.
aspirin.
Mm-hmm.
Let's just start with that. Aspirin is an anti-angiogenesis med. So it stops the growing of the vessels
Mm-hmm.
around the tumor. There's doxycycline, which picks up and prevents the autophagy from happening. There's a lot of things that have really uh, clinical diagnoses and have been studied. And those things are, before I even had my staples out, I was looking for these things.
Mm.
And I asked a doctor if he would prescribe it for me, and he refused, which is fine. But other doctors have not refused. And as of like whenever I got off trial, I got back with the repurposed meds, and I did this cancer oncology, which is out of the UK. The US version is like hit or miss, and that is a 4 drug protocol. Yeah,
Four drug protocol.
atorvastatin.
Uh-huh.
Yeah, it's a statin. It's an antibiotic. It is mebendazole, which is a helmintic, anti-helmintic, but it also is repurposed because it has other options. It has a losing my words. It has other uses. Mitotic spindling it prevents, and
Who
metformin.
you mentioned that organization? Who develops these regimens? Is that's an organization in the UK that focuses
And
their
the US.
and US focuses their energies on repurposed meds, and do they study those combinations
Yes.
in folks?
Yes.
That's fascinating.
Yeah.
So maybe I'll rewind a little bit, Ruth, back to where we were in the treatment protocol, because that was one of the things I wanted people to hear was you're at Inova, you have your team, you end up firing your pathologist, and you find another team
No,
at
my
NIH.
neuro-oncologist.
Neuro-oncologist, sorry. And you find another team at NIH. How did you, because we were kind of talking about that, I don't know that patients know that they're empowered. You had said that and you don't have to tell them they're fired like, Trump would or something, but you can just say, I'm getting a second opinion and I found another doctor. So you can go online and find other people in your area or further away to be a second opinion. How did you find those people, Ruth? How did you find the folks at NIH? How did you connect?
Well, another doctor on our team sent me the information of there was a trial going on up there, and I'm really grateful to the 2 people that pointed me to it, because that was it's hard to get in that one because you have to go in the 4 to 6 week period before you start standard of care, and most people are so just slammed with the feelings and the depression and everything that happens when you get told you've got GBM.
Mm-hmm.
It was hard, and I think it's much harder for people that don't have any medical information at all, and they don't trust that it'll be okay.
And so am I hearing this right? Like for that specific trial, you had to be in contact with those people and start the intake process so early.
Within a week of my surgery.
Yeah, okay. And then a lot of people are not
even able to think that way.
Yeah, right, absolutely. How would you be thinking, get me into all the latest trials and let's review what trials are available and I'll be there, 1 week after my surgery? That's only for someone who's either got a team who's funneling them in there very quickly, or someone like yourself with a background in healthcare who's just has a knowledge.
And that's unfortunate.
Yeah, that's right.
The time it takes to bring. Go ahead.
I was going to ask you, Ruth, that specific trial, did you look at multiple trials that were available? Was that the only trial that was available?
It was the only one closest in combination with standard of care, and I felt like that was when you need to hit it.
And you, being someone with a background in healthcare, they kind of gave you the spiel like, hey, this is the medication we're looking at or the agent we're looking at that's being trialed. Here's the science behind it. And you said that all sounds good to me. Is that sort of a quick synopsis of? Yep. Okay. And
took me about 15 minutes to make up my mind.
Is that right? Okay. And
hung up, discussed, call them back.
For people listening, I mean, there's a government website, clinicaltrials.gov, with all trials that are active that you can go peruse. But Ruth, I think you bring up a really good point, right? Like, look, these trials are in various stages of completion. They may be open to enrollment, they may not be. And then there's a practical element where if the center's involved,
how are you going to get there?
Yeah, how are you going to get there? If you're in Virginia and the trial's actively enrolling, but it's in Oregon, and you have treatment standard of care treatments that you got to keep up with? You have surgery that's part of this. You got a family. Are you getting on a plane and complicating life in that way? You may be. Plenty of people do. But you ultimately had a trial that was fortunately in your backyard at the National Institute of Health, and you took a quick
Right,
look at it. And
Bethesda.
didn't take long, and you were in. The idea of being, you already answered the question, but anyone who might have apprehension about being in a trial where you are technically a test subject, like they're seeing the impacts of this drug on you, did you dispense with any fear there quickly because of the seriousness of the diagnosis, or did you linger on that and say, gee man, I don't know if I want to get tested on? What was that like?
I didn't mind getting tested on, but when I went in, I recently apologized to my nurse practitioner that is with that program, and I said, I came in here like a fire breathing dragon, and I'm sorry.
Did you throat punch anybody?
No, I didn't throw a punch at anybody.
Okay. Just checking.
Um, it was just, I was so angry about the diagnosis. I was angry that I hadn't caught it sooner. Given my background, I was stressed. I'm putting my family through this. And we had to go up there every stinking day and get my radiation and my chemo and this drug. And so it really, I could feel the stress on our family unit. But, I went in there kind of angry. I complained about a couple of things that now I look back and go, that was so stupid. You should not have complained about that. But in the moment, you can't second guess it.
Yeah.
You're advocating for yourself, and it's a scary place to go outside of the norms, go outside of what people are telling you to do, and you're not sure, but you want to be sure, but you're not really sure, and then you're complaining on top of that. And Megan, who is my nurse practitioner, she's such a sweet soul. She goes, "Do you really think this is my first rodeo?" And I'm like, "Yeah, probably not."
Yeah. Yeah. You said something there going against what people were telling you to do. You felt did you feel supported doing the trial, or were people saying, "What are you
Oh
doing?"
yeah,
Yeah, you did. Okay. No.
yeah. They were my cheerleading team. They still are. I love them. I don't want to once I get attached to some people, um, I don't want them to be disappointed.
Mm.
So I'm getting rid of this GBM.
Yeah, very fair. And I think that's one of the takeaways, I think, is for people who get the diagnosis, and Ruth, you mentioned this, people saying, look, the technical the technical advice or the current clinical data does speak to, can't remember the latest number, but 9 months average survival, 10 months average survival, depending on the study. But what's always been true is a recognition that is a heterogeneous data set, meaning,
Right. They include everyone.
yeah, meaning clinicians have always sort of scratched their heads and said, okay, the average is 9 months, but why do we have 6-year, 8-year, 20-year survivorships? And I'm not a brain tumor subspecialist. We'll be talking with one shortly, but my understanding of the latest was, as they get more and more genetic data on what has been painted with a broad brush as, quote, GBM, there's actually probably a number
So many
of
subtypes
that have different genetic profiles, and the thought is that explains this vastly different survivorship profile for folks. And in the future, almost aside from new and novel treatments, is the hope that we'll be able to get a detailed genetic profile on what is today just called grossly GBM into a number of different subtypes of GBM that we can give more accurate prognostic data to patients on. And that's very much a robust area of research currently, and we'll review that with some experts down the road. I don't know if you have anything you want to say about that, Ruth. You probably know more than I do about that. I'm sure.
Um, Given that the average is 9 months to 18 months, uh, there's not enough time to wait for new drugs, new genetic theories, new whatevers. It's going to take so long to bring them to common cause. That is why, and I knew that it was going to be a slog, and I knew that I would have this trial, and then after that, I need to figure out what else I'm going to do. I would say it just takes too long, and people are dying, like people are dying, Senator.
Yeah.
um, um, I it's just a tough situation, and so I have no apology for people thinking that I should not have gone into PubMed and figured out my own path or my own protocol. And I was helped by other people this past year on how to do it. And
Is
I'm not going to apologize for that.
is that um I don't know how to phrase this. Is that a good summary of all that you've done, Ruth, from a treatment standpoint? Like if I'm to reflect this back to you, you went through standard of care, which anyone who is engaged at a
Trial.
up to date medical center would be offered or have access to standard of care, and like we said, that's surgery, radiation, and chemotherapy or immunotherapy. Then as a next layer, patients can choose to say, all right, that hasn't really solved this problem. I'm going to look for research and enroll myself in clinical trials.
Right.
Those will come to completion. I suppose you probably are not candidates for, this might be a question for you, Ruth, and I should probably know this, I'm not on the clinical trial side. Once you've done a clinical trial, are there additional trials you can do, or do you then depopulate
Yep.
out of those? You can. Okay, so you could do multiple
I can. And
clinical
if I have
trials.
a recurrence, I will go in this direction. If I have, you know, there's other cancers that might
Metastasize.
metastasize.
Yep.
Blah. um,
And that opens up other clinical trials if it
yeah, it does.
metastasized. So, and you're plugged into that, like
Yes.
Yeah, okay, that's good to know. And then, so there's the trial arm of it, and then
Metastasize. Got it.
you got it. There's the repurposed medication side of it, which you've kind of touched upon. Is that the whole picture, or is there, from a treatment standpoint, or are there other things you're engaged in? Or is that a good broad overview of how you've managed this from a treatment standpoint?
Well, I also keep busy.
Yeah, fair
And
enough.
but I found the interview with Dr. Kelly um, very interesting because I also have a fascia release person, and I also go to rehab to perform, which is about. I said it was about my horse where I fell off, but it also helps me with my reconnecting of neurons and reconnecting with my balance and reconnecting with the things. And it's just a more holistic global overview of I do this, low GI diet, exercise, always moving, except for now. And it's just a big global picture, and you have to paint it for yourself.
Yeah, fair enough. There's a diet element, Ruth. Like you have a certain nutritional
Yes,
protocol you follow. Yeah.
and that's the other guy that you were talking to. I completely agree with him. The
Oh, he
standard
was
American
fascinating.
diet, which is called SAD,
Yep.
is not doing us any good. And I think that I would prefer, well, I do, uh, closer to vegan or, but not farmed animals. They have a lot of antibiotics and other things in them. And I think that cascades through the food chain.
Hmm. So you do. So your current nutritional kind of approach is close to
Plant
vegan,
based.
plant based, and as organic as possible.
Yes, absolutely.
Sorry, you also touched on, and I'd asked the question, what's the kind of comprehensive view of all the things you're doing? And we discussed all the treatments, and I'm just picking up, you said Kelly Starrett was someone we interviewed, and he's a mobility and physical therapy specialist. So you're doing physical therapy on you've kept that as part of your regular kind of
Yeah,
regimen, just to keep mobility and movement at the top of mind and get the tissues
right.
mobilized and all that. And you feel like that helps from a central nervous system standpoint. Sometimes that stuff can be
Absolutely.
described as like a massage for the internal nervous system, because you're just moving your body, works in so many settings. And then
Right.
there's a nutrition side where you're mindful of your diet and
Yes.
your plant based. Anything else you're actively doing as part of what you would consider lifestyle treatment that you do because of your diagnosis that you didn't do before?
Well, I don't work with you anymore.
Fair enough. Yeah, low stress,
I'm
right?
joking.
You've cut stress
I'm
out.
joking. Um, that's pretty much it. Although I just can't think of anything else. I mean that's my whole day
Yeah.
packed. Like you have your intake, you have um, meds or pills or supplements or whatever you are choosing to take on the side, and then you got to get out, got to exercise, yoga, uh, horses all day long. That's pretty much it.
Anybody in the forums you've had, do people talk about or advocate from a mental health standpoint, like therapy?
Oh,
Uh,
yes. Yes.
I guess
And
that's
I have
another
been
point.
offered, go ahead.
Um, I would say something else we've talked about already, but I would put in that category is you are engaged with a support community through these connections you've made.
Right.
Um, and if someone's at home and maybe not digging into PubMed and making connections, I think an important takeaway is through your journey, there is, while that may not be technically under the mental health category, it's like you are doing that, right? You already mentioned it, innumerable new relationships of people who
Yes,
have a shared diagnosis. That's very much an active thing that isn't just, correct me if I'm wrong, Ruth, isn't necessarily offered to people. You sort of cultivated that, and that's probably an important step.
it is. I recently lost my best friend who was a GBM patient, my best GBM friend. And that really um, hit me hard. So I understand what I'm working with,
Yeah.
but yeah, it is a community, and I'm not trying to neglect my other relationships, but it's a full life too. And I was offered therapy through the NIH And the only time I've taken them up on it is when my mother passed. And I felt like I just need to get this stuff out
Yeah.
and hand it to her and then get back to living.
Yeah.
And that worked.
Do you find your connections who also have GBM, do most of them use therapy as an outlet? Do few of them? Is it a
I
common
don't think
thing?
many of them do.
Huh. Interesting. And maybe one other question, Ruth. I don't know if you followed any of this, like the kind of reemergence of psychedelic research. Johns Hopkins sort of pioneering this for
They're doing
end of
the
life.
psilocybin.
Yeah, psilocybin and that kind of thing. Do you come across a lot of people in your support groups that have looked into that? Is that really catching on or not so much?
I can't really say that it's catching on. One of my friends and I have discussed it. I don't want to go there,
Hmm.
but
Just
that's just
wondering.
me. I don't care for drugs.
Fair enough.
That's really weird to say, but I'm not in it for the high or
Yeah. Yeah, I would imagine that's
but
probably not for everyone for sure, but I know there's been a big reemergence from a research standpoint
right.
um,
And
around
I
it.
followed that research and if I ever needed it or wanted to do that, I probably could.
Hmm.
Um, just don't.
I don't want to keep you forever. What where your current maybe to like kind of leave folks where you currently are. How often do you get scans at this point? Like, are they scanning you
Every
every
3 months now. In
3 months?
fact,
You
I
get
have
scanned.
one coming up in a few weeks.
Do you post all of them?
No,
Because that's what on Facebook. I'm
I
always seeing the posts, and it's like I wonder if Ruth posts all of these, or if she just landmark ones, or how do you decide what to share? Like, how do you do that?
that's a good question. The first time I posted, and I got pretty raw and real about how I was feeling about things and that I was going to fight this. And I stood up in front of my team after I'd just gotten my staples out and told them, and following Dr. Zhu, who was doing a presentation on GBM, and that was one of the neuro conferences that I used to attend. And I got up in there and said, I am going to fight this, and I'm not going to. I cursed a lot, and I was embarrassed about the cursing, and I came out of the surgery cursing, but I forget where we were with this.
Oh, I'd asked
I
how
don't
you.
post,
Yeah.
yeah, I don't post all of them. I post the ones that are relevant to what's going on in my brain,
Yeah. Yeah.
which has seen a lot less change here lately, and I hope it continues to see a lot less change.
Yeah. Me too. Um, I can't. I think we're probably out of time
Have
right
we
there.
exhausted all your questions?
I think so. I don't want to drag you through it anymore. I mean, it's not. There's not really a time limit because, like I said, we edit it all, so it's like we could make it 15 minutes if we wanted to, and we'll show you like when they edit it together. We'll give that to you before we post it up, and if you change your mind or want something, recut or cut
Removed?
out, just that's how we do it. Um, we tend like everything we've done. Correct me if I'm wrong, Suzanne, but everything we've done, we cut little reels out and put it on social media, and then the podcast sits on
Hmm.
Spotify, and we've just put whole episodes up. I don't, I, I don't know if they. I guess I don't know if Spotify has like a limit where they say, look, you can't put it all up. But everyone we've done an interview with, we've just said, look, let us know. This is what we chop together. If you don't like it, we'll change it and go from there.
Okay, I'll watch it.
Thanks for your time, Ruth. I appreciate it. Sorry we couldn't make it down there. If we
Well,
if
you
we
know
came
where.
if we came down, were you going to put us on horses?
No, I would
Okay,
not do that to you.
just checking.
One of my horses is an Irish sport horse, and I've ridden her several times. Uh, but she threw my trainer last week,
Oh wow.
and I was like, no, I'll just wait. I'll wait till
Yeah.
you install all the buttons.
There was this is
So
an
I'll ride the
embarrassing
black one.
this
Huh?
is an embarrassing story. When I was in medical school, I had a girlfriend, and she was into horses, and she had a. This may be common. There was a woman in Washington D.C. I went to medical school there. A woman owned a horse, and my girlfriend had made a connection with her to ride her horse, and it was like a mutually beneficial thing. The horse needed to be ridden throughout the
Right.
week, and the woman who owned the
And that's how
horse.
yeah, I started with my trainer uh, that way. She offered to come out and ride my horses.
Okay, so we
Yeah,
so my girlfriend at the time would go ride this horse that this woman owned, and so she brings me on like a date, and she's in riding gear on this beautiful, big horse, and she looks like she's out
right.
of, a professional horseback rider, right? And they stick me on this little mule looking horse, and I don't have any gear, so I'm in like shorts. And then there's this picture of the girlfriend looking really great on this big huge horse, and then I'm like,
Suave.
I look ludicrous in, street clothes on this little pony looking thing that I'm too big to probably be riding, and that was very
Actually, you
embarrassing.
were probably safer.
That's why they put me on it. Yeah, they were. I was like, why do
Yeah.
I get the little horse? They're like, no, no, you're on the little horse, buddy. And my only other memory of that, Ruth, was she would, when we put the horse back in the stable, she was brushing it and standing behind that thing. I was like, we should get out. This thing is enormous. The
Yes.
muscle, and I was like, what if this thing kicks? And she's like, oh, he won't kick. I do this all the time. And I was like, I am uncomfortable in this situation.
Well, south side of a northbound horse.
Yeah, yeah, that's right.
You shouldn't stand behind the horses if you don't know them, and probably not if even if you do. But I tend to brush their tails and stand a little bit to the side. But you're right, that's a big horse.
Yeah, it was scary, man. All right. Thanks a lot, Ruth. Really appreciate it.
Thank you. I enjoyed
Any
it.